The session is open for discussion. Any questions? May I start? So one thing which is an absolute indication, you showed that the timing for that is 2 weeks. Do stick to that or you extend it to 4
up
weeks?
to 3 weeks would be the stretch, because biofilm depends on the type of organism that you have. Some organisms develop biofilm very rapidly, within even 5 to 7 days, whereas some organisms take up to 2 to 3 weeks for it to develop. 2 weeks is supposed to be the critical period, but it can, physically, practically you would maybe stretch it out to 3 weeks. But beyond 3 weeks, definitely it becomes a chronic infection. There is no point in doing it again.
My question is regarding the instability of knee. So, Dr. Subhash, you discovered that once your components are, you are revising a case and you have an MCL insufficiency. You can revise your component, you still find there is a medial opening. Which of the two options will you go for? Go for a more constrained knee or do a ligament reconstruction and check again on the revised implant?
So you're doing a revision, right? In a revision scenario, you first put your trial components in, and I usually take a trial with my primary PS insert. If with that there's opening, and that opening goes away with the constrained poly, then that's the definitive solution for you. Even after putting the constrained poly, there's an opening, that means you have to move to the hinge.
In no case you will be resorting to do a medial corner reconstruction, a ligament reconstruction.
No, I will not opt for that.
When will you go for a ligament reconstruction in a primary knee setting?
So in my opinion, the MCL injury happened during surgery, and I've seen presentations during conferences that people have reconstructed the MCL and done that. I have never done that, and probably I don't believe in that construction belief that you should reconstruct the MCL during surgery.
Just a quick.
Maybe we can take open from the other people who have done the. Anybody has done the MCL reconstruction during primary surgery?
I've done MCL reconstructions in native knees, and also there the results are only limited. So with the prosthesis, I wouldn't risk it.
I think Dr. Hemant.
Reconstructions. We are not talking about refixations. We're talking about reconstructions with tendons.
No.
You have a refixation if you have avulsion from their femoral or tibial leg.
Avulsion.
You have a cut there at the. He's
then
talking about the cut at the MCL.
If you have diagnosed that cut during the primary surgery and you actually define that this is the area of laceration, either complete or partial, then you could, provided if you don't have any other avenues there, what I would do at that stage, so suddenly the gaps open up, and that is the way it comes to diagnosis. So if you diagnose it during surgery and you can define that area of, laceration, then you can reconstruct that using ethibonds, but there is a technique of doing it. You end up putting a much thick.
You will be using the tendons, gracilis or semitendinous.
No, that semitendinous gracilis could be an overkill there. What I'm suggesting is that end up using the gaps become bigger. So suppose you are testing initially for 12 and suddenly 14 and 17, is going in. But then use the most appropriate thicker poly, have the final implants in place. But before that, putting the final implant, you can, use your ethibond tool of number 5 ethibond. I would have, running through the length of the MCL and coming back and, suturing on itself. We have 2 lengths of that. So 2 sutures, but then put final implant in, get the knee in figure of 4 position so as to maximally close the medial gap and then really tighten that MCL and then protect the knee for 6 weeks.
So that is, you are doing a acute MCL repair.
Acute MCL repair I'm talking about. Not a reconstruction.
So, a few questions regarding the DARE. How do you do the posterior clearance and posterior synovectomy?
See, posterior synovectomy is difficult. You can only use a curate there, or maybe use, if it's something, protruding, you can just use a nibbler and try to clear out. It's going to be a very limited posterior clearance. The most important part of poly, change is actually getting under the poly and clearing all that tissue that may be underneath. And, reaching the corners. But there's going to be limited debridement of synovium posteriorly.
Okay. You can use a brush as well.
Yeah, but again, limited. You can't really do a thorough.
Yeah, the brush part. One more thing. I was just reading about an article. What they do is called as double DARE. Okay,
Yeah,
double
do it
DARE.
twice, two dares.
So what they do is in primary, they will just wash it out, retain the same everything, just clean it out completely with brushes and everything. They will come back once again after 5 to 6 days. They will change the poly and everything and do the surgery, kind of a double DARE. That is also they feel that they increase the outcome of the result from like 70% to 85 to 90%.
So that also helps in identifying the bug also sometimes if the
Identify the bug also.
I have done a version of that. There was a personalized prosthesis with a personalized insert, which came on a Friday evening. I couldn't get an inlay for it. So I just scrubbed everything, scrubbed the inlay with my toothbrush and just put it inside. And it stayed. It didn't go up. Same poly back in.
Same like 1.5.
Same poly.
like,
because I did
1.5 stage
1.5
revision.
stage, the boys from Arizona do that in the
Arizona,
US.
I think the double diar is from Vade. This is from also with this. They are also doing it. Double diar is 1.5
Yeah,
stage.
1.5 stage is where you put the beads in with your scrubbing.
In 1.5 in TKR, what they suggest is you remove the poly, okay, and you put a cemented poly, okay.
No, 1.5 they are showing is a lousy cementing. Do lousy cementing and hope that the first stage itself works for 5-7 years.
Exactly. And they just change the poly. They put, but they block the femoral canals, TPL canals completely, so that there is no growth of organism inside. So that is how they do 1.5. But it's very limited. Even double diar, there is only one center who is doing it, who have a good idea, but there is no outcome for it.
So does diar have a different outcome for early onset infection and late onset infection?
There is no contraindicated in late infection. What do you mean late onset? From the primary surgery?
From the primary surgery.
It's only for hematogenous seeding of happening very late. It's for late hematogenous infection, with acute setting. It comes on acutely.
No, if there is infection after say 1 year, 8 months, then
Yeah, then it is there. It is
That's a
suitable
late
for there,
hematogenous.
provided it comes in time.
So I think the 1.5 stage is basically you remove all the implants.
Yeah. It is
It's not
one
done.
stage. It's actually one stage revision,
it's not
doing
done.
it
It's a
badly.
two-
Yeah,
different
it's a poorly done one, second stage. Hemant, have you
Yes,
found that when you're doing diet, the size of the poly increases normally?
Yeah, it does.
So
That's what I showed. From 12 to 14,
Yeah, so you normally have an increase in size of poly. And the other thing about the MCL thing, so I think it's very difficult to cut the MCL, but even if it is cut, so you can suture it back and use augment it with the semi-T if you don't have anything on the table. Other thing, most commonly what happens is you over-release the MCL, especially the anterior part sometimes. So inflection starts opening up, in extension it's fine. So in that you need to, so MCL is a differential function. If you see the Whiteside's article, so the anterior part functions in flexion and the posterior part functions in extension. So that is something that sometimes happens. So you need to be careful for that. That you can resuture it back with the transosseous sutures using Ethibond. And then post-op, you have to be a little careful about mobilization. Maybe use a hinge brace, not limit mobilization, weight bearing, hinge brace for some time.
Yeah, 6 weeks.
And other thing that Dr. Maheshwari told me some time back was that, lots and lots of years back, if you have any problem with MCL, your knee should be in varus. Overall alignment, if your overall alignment is in varus, it will not fail. Means,
That's logical, isn't
I
it?
think
That's
Dr. Maheshwari
logical,
remembers that. Around 10 years back, he told me some years. Yeah.
Pearls of wisdom.
For beginners, you have to identify MCL injury on the table. When can you identify? You have made all the cuts, you have done trial, and at the trial stage you realize your MCL is not working. That's a different scenario. Other scenario, you cemented your components, and now you realize your MCL is not working. These are two different scenarios. So if you realize it at the trial stage, you have that choice to repair the MCL and give a little varus to the femoral component, intentional varus. How you can do it, you know it. You can cut a little varus and let that knee be in 1-2 degree of varus. I'm talking hypothetical, but it's always possible to create a little varus so that when repaired MCL is not under stress. If repaired MCL is under stress and alignment is valgus by any chance, whatever you may do, it will fail. Second option is we are cemented already and now you have realized that now it is mandatory to not only repair, do a reconstruction. Take the semi-T, do whatever possible and immobilize and do everything possible and hope it will not. And I always take a hip knee ankle x-ray immediately after the surgery, next day, to realize what is my overall alignment now with MCL being plus minus. And I delay my weight bearing as much as possible if I have no other option, based on my alignment.
A useful technique is to have a tendon stripper, leaving the semi-T attached distally, and then loop it through the middle, make a hole in the middle epicondyle and loop it on itself and suture it. That's the additional.
At trial stage, you also have an option of putting a constraint implant there.
Sir, my question to Dr. Hemant sir. So as you said, in infection there is a. Sir, I'm here.
Okay, sorry.
So there is an increase in poly size, and we all have seen that. So what is your observation? A early infection, like let's say 3 months, 6 months, or a year, do you see a poly increase, or do you see in late cases of infection? And second question, your take on why it is happening so?
No, it is essentially the enzymes that are generated, isn't it? The collagenase. The enzyme, it's enzymatic degradation of the poly or the soft tissues or the collagen inside in the tendons, on the ligaments. So that is what is causing you the laxity of the soft tissues.
So if, let's say, if the patient delays for that infection, if the infection is there in the joint and we take a lot of time to open it, then the chances of poly increase will be higher. And
but if you're delaying it, it's anyway not suitable for DARE. So you need to do a two-stage
I
revision.
think you need to make it very clear. DARE is only successful if done within a month. Month is, I think, the maximum.
Month is also stretching it too far.
Stretching it.
3 weeks
Ideally
is
2 to 3
weeks.
of a primary surgery, or if it's a hematogenous, then also from the onset of symptoms.
Correct. Absolutely right.
3 to 4 weeks. Not
So I think this is an important issue for the beginners. When you have suspected infection in your patient, it's my patient now, and 3 weeks down the line, I'm suspecting infection, and doctor says you should not do a DARE in 3 weeks' time, and I know I cannot go in and remove all the implants and be a very brave surgeon. You have to face the situation. So is it theoretical to say 3 weeks, 4 weeks, 2 weeks? Or I think as a human being, as a human surgeon, I will have a tendency to extend that indication to maybe 6 weeks, 8 weeks. I know it is going to increase my failure rate.
The important learning point here is that if you have your own patient getting infected or leaking wound, do not wait, do not procrastinate, just go in and wash it out and debride it as soon as possible.
I get Dr. Maheshwari's point of view, but the only thing here is that the chances of success becomes less, and I think if you tell the patient that thing, we have to do it sometimes. Sometimes the patient is not fit, sometimes but you need to tell the patient that it might not be successful, and that is it. And
bite the bullet.
You have to bite that humble pie or bullet.
Do you have
another option?
I think one more
Sooner
thing.
you do it, better it is.
One more thing I think for DARE, I think all the samples what we send should be sent by different instruments. If you use the same instruments for all the sample what you're sending, the chances of having, which is very high, there are certain people who talk about like 5 samples or 6 samples, but all the things should be with a separate instrument.
so again here,
If there is an infection session, I think a lot of things will come up in that session. But I think what do you send for, in the samples? So send for aerobic, anaerobic, AFB and fungal. So that makes that is a complete battery. You have to save the sample for some biofire and, if required for next gene sequencing, NGS. So all of that has to be kind of kept available. You would not immediately go for biofire, but you have to keep the sample, save the sample for, if suppose everything comes negative, you might rely on it. It has happened to me that everything came negative, but biofire picked up Klebsiella for me.
So do you send it for
BD. Yeah, Hemant, have you had occasions? Yeah, Hemant, question to you. Have you been in a situation where you start off with a planned DARE, and after opening you've changed your mind and removed all the implants?
It happens once in a while that you feel that the implant is not loose and you actually find some loose laxity, and then you have to actually remove everything. You have to warn the patient beforehand.
Yeah,
that if,
so
there's no point in going ahead with DARE if the implant is already loose.
Yeah,
that means it's a chronic infection.
you might find some bone erosions and
So you should always check the posterior condyle of the femur. That's the earliest area where if you find that's loose, then you go for a 2-stage or depending 1-stage revision. But always take consent for both.
Yeah, Hemant, since we are on DARE, using stimulant, have you found that it oozes a lot?
Stimulant should never go into the subcutaneous area.
Yeah.
That's absolutely critical. It has to be deep, under the arthrotomy, a watertight closure of the arthrotomy. Because if you have stimulant in the subcutaneous area, it will keep on oozing and you will know what's going on. Especially in the hip.
Where do you put the drains then? Where do you put the drains?
I don't put the drains.
Yeah, so another thing is that
I never put the drains.
Yeah, so another thing is if you're putting some antibiotic, it's wiser not to put a drain.
Yeah, absolutely.
And if you're really forced to put a drain, maybe sometimes we put a drain, but we then, clamp it for 24 hours, just open it for 15
Take it out
minutes.
quickly, take it out quickly.
Yeah, and just take it out.
Because those stimulant is going to disappear in 5 to 6 weeks.
Do you have an empirical antibiotic regime for every case?
Yeah, we have an ID specialist in the hospital who helps us a lot. So that I think having an infectious diseases specialist available locally is a great boon for all orthopedic surgeons. We believe we know a lot about antibiotics. Believe me, we don't.
It is also about sharing responsibilities.
Well, they can say that.
But say
PGI is a multidisciplinary. You need to have a good microbiologist, infection control head, sometime a plastic surgeon involved, and all.
Yes,
It's
of
very,
course.
very important. It's a
Yeah,
very,
absolutely. No
actually,
trick.
I think infection in joint is worse than a cancer. I feel because there is no support group or something. And if it is your patient,
That's true. You're on the.
There is
no support group.
You are always at the receiving end the moment the infection occurs. Your neck. That is the most important part. And the arbitrary 3 weeks time, I think Dr. Hemant has rightly said, should be followed, but it is the clinician's judgment which makes the entire change. But doing it later, I think, not much later, 1 month or 5 weeks, also not make much difference if the clinician sees clinically. And it is like purchasing a lottery ticket. If you have purchased a lottery ticket, you are liable to win the lottery. But if you have not purchased a ticket, you are doomed not to get anything else.
And the reflex of putting patients on antibiotics has to be desisted. Should not be putting on antibiotics unless you take samples. Aspiration is such a simple thing for an orthopedic surgeon. So do it in your own clinic, get the samples, and then do whatever you like. Yeah, then doing a sonography, yes. You can't do orthopedic surgeon doing sonography is really serious, I think.
Thanks a lot.
So can we proceed to launch?
With these two pins, these optical trackers are basically 3 eyes that robot detects. So these are 3 eyes that robot detect. Then after attachment of the optical trackers, we actually register the center of the hip, center of the knee, and ankle. During hip registration, we usually rotate the femur to acquire the center of the hip. Then we register the medial and lateral malleus. Then we register the center of the tibia, medial condyle of the tibia, and lateral condyle of the tibia. Then sagittal axis of the tibia. In femur, we register the center of the femur, right sides line, medial condyle of the femur, followed by lateral condyle of the femur, then posteromedial condyle and posterolateral condyle. And at last, we register the anterior cortex of the femur. After this registration, actually, then we check all these points on screen, whether all our points are we actually validate all these points on the screen, whether our registration is correct or not. So green signal means everything is okay, and red means we are far. Red signal means we are very, very far from the validation points or registered points. So after the registration, we just flex and extend the knee to see the range of motion, how much medial and lateral opening is there. So now I'm going to flex and extend the knee with a gentle valgus and varus thrust to see how much opening is there on the medial as well as on the lateral side. So in this screen, we can see on the left side is the pre-operative, and on right side it was basically my planning. So after doing planning, I had decided to cut the tibia in a 0-degree varus and 4-degree posterior slope, and 8 mm resection from the lateral condyle and 4.5 on the medial condyle. So with the help of robotic arm, I'm cutting the proximal part of the tibia. So after cutting the tibia, there is a device known as sensor tensioner. We put the sensor tensioner inside the gap and again recheck the flexion and extension gap. So this time extension gap is 9.5 and 10 on lateral and medial side, and 12 and 11 on flexion gap on lateral and medial side. And my varus is almost corrected from 0 to 1 degree, and range of motion is around 120 degree, 120 to 125. So again, before cutting the femur, we do the planning. In this case, I am enterizing the femur 1 degree, 1 mm, and increase the flexion gap. So I had upsize the femur from 4 to 5. And since all the 4 gaps are more than 1 mm, 1.5 and 1.5, I'm going to increase the insert size from 5 to 6. Once I will increase the insert size from 5 to 6, it will balance all 4 corners of the knee. So now my knee is perfectly balanced. So with this planning, I'll cut the distal femur. So distal femur resection, I have opted for 9 mm from lateral side and 7 mm from medial side, 0 degree varus and 3 degree flexion. So this was my planning intraoperatively while distal femoral resection. After distal femoral resection, we resect the femur anterior and posterior, and then both the sampers. So posterior samper. And anterior samper. Then we remove the cut bones from soft tissue. And we can remove the posterior osteophyte with the curved osteotome if they are too big. Then we cut the box with our conventional instrumentation. It is basically a Wallace system that is semi-assisted, semi-automatic type of robot. This is a saw-based system. So once we remove the box, we put the trial implants, trial femur and trial tibia inside, along with the insert, and check the graph again. The plan that we have decided intraoperatively whether we are able to execute it in post-op or not. So I put the femur and tibia and check the graph. So now it's a almost perfectly balanced knee, almost 0 to 0.5 mm opening on medial side and 0.5 to 1.5 on lateral side. So this is basically a very basic video presentation of a very simple varus knee. Then we remove a little bit overhanging bone on the femur, and we prepare the tibia as routine. Then comes the cementing part. In all the robotic system, cementing and component placement you have to do by your own hand, whether it is a fully automatic or semi-automatic. All the cementing and implant positioning you have to do by your own hand. Robot is not going to put the cement and implant. So I am the tibia surgeon first. Actually, I put the bone cement on the proximal part of the tibia, then put the tibial base plate. Then I put the cement on the femur and place the femoral component followed by spacer. So this constitutes the whole surgery.
So is a robotic knee replacement better than conventional? So Dr. Mohit Gupta is going to tell us about it. Can I request Dr. Mohit Gupta to come on stage? Now the people who are showing out their posters, they have to report backstage. They have to go into the back room, behind these stalls. Dr. Mohit Gupta.
Thank you.